Yeah, healthy good afternoon, everyone. So before I start, I want to thank Punjab Ophthalmic Society to select my paper as the best of the state. So today I'm going to talk about the role of primary vitrectomy for the management of the subfoveal hard X-rays. So it has been, slides are not moving, sir? Slides are not moving. So it has been known since many years now that these subfoveal X-rays, they are the common cause of the severe and irreversible vision loss in the patients of diabetes. They lead to RP scarring and the subfoveal fibrosis. So since then, many treatment modalities have been used for treating these subfoveal X-rays, ranging from focal lasers, but these X-rays, they respond really poor to them. Then came the era of surgically excising these subfoveal X-rays, but it was found to be technically very demanding and complicated procedure. Then came the role of vitrectomy for these subfoveal X-rays with a certain supporting facts that vitrectomy helps to remove the tractional forces, it reduces the oxygen consumption, it reduces the hypoxia, it decreases the VEGF load and also help to remove the vitreous collagen. So with the help of this retrospective interventional case series, we tend to delve the role of vitrectomy, but along with ILM peeling for the management of these subfoveal X-rays. So record of 11 under 33 eyes were retrospectively reviewed who underwent the vitrectomy for the complications of diabetic retinopathy from 2019 to 2021. 66 eyes of 66 patients which fit the inclusion criteria, they were included in the study. The plaque size as shown by the fundus photo below was measured with the help of the measuring tool available with Claris 700 fundus camera. The inclusion criteria for my study was the presence of these subfoveal X-rays with the preoperative visual acuity of less than 6/18 with a good preoperative metabolic control for at least a duration of 3 months and with a minimum follow-up period for at least 6 months. We observed that the mean age of my study group was 57 years and the mean follow-up was around 13 months. Equal proportion of the cases fell into the category of NPDR and PDR and the lens status was majority of the cases were pseudophakic. OCT did reveal vitreofoveal tractions and taut posterior hyaloid in few of these patients and majority of the patients have already received the intravitreal injections and the lasers before doing this surgery. So the mean of the best corrected visual acuity preoperatively was found to be 5/60 which after the surgery got improved to 6/36. 47 out of these 66 patients showed the improvement in the vision. With 13 patients, they got improved to equal or better than even 6/18. The preoperative plaque size was found to be 2.172 millimeters square, which got improved to 0.26 millimeters square. And the fundus photo below is showing the representative case of the largest plaque which was operated, and it is showing the complete resorption of these subfoveal X-rays with a duration of 6 months. We kept a very keen eye on the status of the other eye, though in majority of the cases it remained the same, but in very few of them it actually got worsened. So this is a representative case in which the left eye of the patient was operated and it is showing the resorption of these subfoveal X-rays, while in the other eye we can see as we are following the patients the disease got worsened. 100% of the patients showed the resorption of the X-rays with 18 patients showing the complete resorption, and cataract turned out to be the most common complication of my study. So this is a representative case of a 64-year-old male which is showing the resorption of these X-rays with the duration of 8 months and the vision is getting improved from finger counting 1 meter to 6/12. Another representative case which is showing the resorption in a duration of 14 months with the vision getting improved to 6/9 from 6/36. So vitrectomy alone has been done previously, but in that ILM peeling was not done along and the resorption could be seen at a duration of 3 months. In that study, none of the patients got improved to better than 6/60. But in our study, we have combined ILM peeling with vitrectomy and the resorption could be seen as early as 3 weeks, with 13 patients getting improved to even equal to or better than 6/18. So here comes the role of ILM peeling. ILM peeling ensures the complete removal of posterior hyaloid. It ensures the removal of the part of the Muller cell foot plates which lead to the cascade of the chemical events that helps to fight against the breakdown of blood retinal barrier and also helps to repair the interruption of the exoplasmic flow. ILM peeling ensures increase the release of EGFR which acts as inhibitory to the VEGF. So compared to the surgical excision, vitrectomy with ILM peeling is a routine retinal surgical procedure with lesser complications. The limitation of my study is that it's non-comparative. So I would like to conclude that vitrectomy with ILM peeling is a simple and effective way to manage these subfoveal exudates. But we do need prospective randomized control trials to substantiate my finding. Though it is not a primary treatment option, but it could be considered in the cases which are resistant to the therapies before the damage has occurred.